अरविंद, हाँ आप बस बोलना तो मैं।
अरविंद जी आप स्टार्ट कर दीजिएगा अभिषेक जी।
अरविंद आप बोलो लाइव, मैं स्टार्ट करता हूँ।
अच्छा बैठ सकते चार्जर नो यू कैन गो। हेलो
हेलो एवरीवन, welcome for Pedia Talk ECME from Lupin Respiratory Division. Today we have a topic that is management of asthma overlap gastroesophageal reflux disease in children. And to have this, we have renowned and eminent speaker from South Mumbai, that is Dr. Fazal Nabi. Dr. Fazal Nabi is a director and DNB guide from Department of Pediatrics and Neonatology of Jaslok Hospital, and also he is honorable consultant pediatrician and intensivist at Safi Hospital. He is having a huge experience, and he is a member of Indian Academy of Pediatrics. With this, I hand over the session to Dr. Fazal Nabi. Over to you, sir.
Thank you very much. I'm going to talk about asthma that is in children and overlapping with GERD. Always confusion. Pediatricians treating family physicians whether to treat asthma or GERD. Both are different but linked together. Asthma can produce GERD and GERD can produce an asthma. Next slide, please. Next slide, please. Now, what is an accurate diagnosis of pediatric asthma is important, and what is triggering? As all of us, we know that we have read about intrinsic asthma, extrinsic asthma, what is the reason, all that. Now, especially we are talking today about the asthma related to GERD, especially in children. We have a neonates. Commonly, we see GERD, gastroesophageal reflux and reflux disease in neonates. In pediatric age group, it's uncommon, but whenever we find GERD in children, always there is associated, always, not always, sometimes is associated with wheezing. Okay, we have to take an extra effort to diagnose exact what is the reason for an asthma in children. Next slide, please. We have different reasons. The comorbidities, like we have for example, we have a GERD, obesity, okay, obstructive sleep apneas, smoking, COPD, there are many causes. Out of all that, see, there are so many things which can induce asthma-like symptoms. Other than you have a familial and genetic, there are comorbid factors which can induce asthma, but out of many, the most common is the GERD. Next slide, please. If you see, there are many reports contributing to asthma. For example, child must be having an asthma which is a genetically derived, there is family tendencies, a family strong history, there is eczema history. On top of it, because of asthma itself, because of basically underlying asthma associated with the GERD will worsen. We always think we try to control the asthma by lot of medications, preventive steps, change in lifestyle. In spite of that, if disease doesn't come under control, always think there is other comorbid factors which we have already shown in the slides. The comorbid factor, which is a common one, is a GERD. So always do not forget, when you are not getting a response in children as you expected, then think of comorbid factors. Next slide, please. Asthma is one of the most common disease. Yes, all of us we know, children below 12 years, and it's more common in preschool. And then we see the decreased sequence as severity and the frequency of the episode comes down as child grows. Unless until there's a comorbid factor which is continue to bother them, then it can continue in the same severity and the same frequency. Next slide, please. Now, I'm going to go through the many references, but if you see clinical studies shows that GERD is highly in children and asthmatic, with estimates of high, nearly half of the children are asymptomatic. Means The GERD is the disease what we are talking. You may have a GER with a grade 1 to grade 5 reflux, but reflecting back and trickling down and causing a bronchial irritation because of aspirations, that is a very high, but sometimes the mild episodes which have grade 1, grade 2, grade 3 GER may not produce any symptoms at all. Or sometimes already when they get an episode of clinical symptoms, that can, the simple GR which is maintaining around the low grade can worsen his symptoms of clinical symptomatology of acute wheezing presentation. Next slide, please. Okay, coming to regarding this evidence, what is the evidence? How will you rule out? Lot of clinical evidence suggests that there is a disease may occur in up to 2/3 of the children in asthma. Thing is 2/3, 66%, which is more more than can be a expected in chance suggesting associated with the disease uh, disease conditions. Okay, and while this link is generally accepted, the exact causal mechanism is disputed and conflicted theories exist. Always we have a conflicting results, but still the most common is the GERD, which is almost 66%. Some evidence suggests it may worsen asthma, as I said, and contradictory evidence that this is a presence of asthma may in fact worsen the symptoms of GERD. Vice versa. GERD can worsen the symptoms of asthma. Asthma can worsen the GERD symptomatology. It is believed that GERD can result in atypical presentation of asthma and may be mechanism responsible for the existence of the difficult to manage asthma in children. Yes, as next slide, please. Why it's difficult? Because you have to treat GERD and you have to come to conclusion whether it's a GERD is worsening the symptoms of asthma or asthma is worsening the GERD symptoms. You have to treat both simultaneously, but even patient has to change their lifestyle if he has a GERD. GERD is a condition which develops when the reflex of stomach contents, yes, is going reflex is in the reverse direction instead of going forward direction. Okay, that's the symptoms. Next slide. Okay, see, you can see this picture. You can understand what happens at the lower esophageal sphincter incompetence. Okay, that controls as soon as food flows down from esophagus to stomach. Stomach try to contract and push liquid digested food towards the duodenum, and that time the duodenal sphincter, that means the pyloric sphincter, opens up, and same time lower esophageal sphincter contracts. When we have a incoordination, when we have an incompetence of this lower esophageal sphincter, and it just can't close completely, the reverse direction, everything flows back into the esophagus. That's food contents comes along with the food content. The most important, even acid also reverse back. Sometimes they have a lot of acid reflux, that is no food content acid reflux. That causes lower 1/3 of the esophagus. When we find out through barium swallows or sometimes directly upper GI endoscopy, we can see the mucosal roughening in the lower esophageal end, which is secondary to repeated reflux asymptomatic, giving rise to damage to the mucosal lining in the lower esophagus. Next slide, please. The symptoms of GERD, typical symptoms: heart burns, chest burn. Okay, when elderly children, yes, they complain. The younger the child, if you see, they go into opisthotonous position. What is opisthotonous position? They arch back. Okay, they try to vomit. They try to prevent the reflex by arching back. That's the most common children, younger the child. The elder the child who can describe the symptoms is that heart burns. Okay, regurgitation. Okay, they can feel, and even food comes up to backside of the nasopharynx and mouth cavity. Suddenly they get up from sleep because of sudden reflex. Okay, that is the most common. Atypical symptomatics, yes, repeated can cause irritation, mechanical chemical irritation because of food content into larynx, and asthma and dental erosions, pharyngitis, chronic cough, chronic bronchitis. There's so many symptoms of each and every disease, like it can produce these kind of things because of GRD. Okay, and rarely we have even weight loss and GA bleeding because of repeated mucosal damage. Next slide, please. Yeah, as I said, lesser that under 2 years of age, they have, as I said, back arching, irritability, regurgitation, food refuse to eat, they scared of eating food, and cough and apneas and crying excessively, all that. Younger the child, more the non-specific symptoms. Older the child, between 3 to 17 years, more specific symptoms. That's what we need to remember. When you take an history, you have to ask in detail, especially in a bachus who is less than 2 years old. Next slide, please. Thus, respiratory symptoms can be associated with GRD and can be a particular concern in children. Yes, definitely. And patients with the respiratory symptoms may not exhibit typical GRD symptoms or otherwise partially asymptomatic. Thus, establish the diagnosis in this group can be difficult. Next. Okay, now coming to GRD, what is the pathophysiology? Yeah, it's for a clinician, it's a simple. We need not need to go into microphysiology. If you understand what is a functional frequent transient LEC relaxation, mechanical hypotensive LEC, that's a little low tone, flappy, loss of sphincter tone, all that. Example, coffee, alcohol, spicy foods cause further worsening. Medications can irritate this tone of this one. And finally, they can have associated hiatal hernia. The most common cause of GERD. Oh yes, these are the two. And that is a mechanical hypotension and functional frequent transient LEC relaxation. Decrease in pressure of the LEC. That secondary to drugs, medications what we eat and what we take, and food what we eat, and hiatal. These are the common. The most common is anticholinergic, bicarbonate, barbiturates, and calcium channel blockers, NSAIDs, and nicotine derivatives. Increase abdominal pressure. Yes, pregnancy and obesity and intra-abdominal tumors. Okay, that increases the pressure. Next slide, please. Yeah, here it's beautifully described about pathophysiology. If you see this photograph, okay, it's a normal airway here, and here an asthmatic airway. That's in asthma, we see two types of bronchial airways. That's one is you have a inflammatory edema. The second thing is smooth muscle spasm. There's inflammatory edema is because of repeated recurrent irritation to the airway that causes inflammation, allergic inflammation, and edematous airway. Spasm is a common response. Okay, this is histopathological demonstration. Next slide, please. The respiratory symptoms may be caused possible mechanism, so-called reflux theory, aspiration of gastric, or the reflex theory is acidification of the lower causing. Means the food content coming back, or stomach acid is reflecting it back. These two, both these theories carry supporting strong evidence. Next. Asthma in adults also have a high gastric pressures, lower pressures at the lower esophageal sphincter, both facts that encourage GRD and support the reflex theory. That's in adults. And conversely, the reflex theory also carries a considerable evidence. Okay, it is believed to occur through dysfunction and dysregulation of the common vagal innervation of both the lungs and the esophagus. The nerve supply common to the airway and the lower esophagus. Whenever you have a little mild grade 1 reflux, The nerve ending understand there's a reflex content is happening of acid and food content. The nerve sends a signals to the lower esophagus to go into spasm and contract the sphincter, lower esophageal sphincter to prevent reflux. The same, the common nerve supply to the bronchial tree, that also sends a signal to the bronchial tree saying that goes into spasm. That's what it happens without aspiration, without any content going into the windpipe, the airway. Child can produce a wheezing episodes. That's secondary to common nerve supply to the lower esophagus and the bronchial tree. Indirectly, it understands that I had to prevent this reflex by going into spasm. And the same time, the reflex, common reflex goes to the bronchial tree that causes into spasm. Next, like additionally, studies have shown that acid perfusion of lower esophagus can cause bronchoconstriction. That's what I said, and human studies. The exact mechanism by which GERD and asthma are currently poorly understood, but yet only uh, a temporal association has been proved, with a lot of studies favoring these two in association. Next slide. Given current knowledge linking this condition, it is increasing importance that respiratory clinician is aware of the appropriate GERD diagnosis and tools. And there is significant in asthmatic children due to increased prevalence of GERD in the general asthmatic population, but particularly relevant when dealing with the child with an asthma, what is unresponsive to standard therapies, since GERD may be contributing to the underlying problem. Whenever you are treating a child, when you do not see a expected response. Next slide. Okay. Vice versa. As I said, is a GERD and asthma. Asthma can produce GERD. And aspiration, bronchoconstriction, hypersensitivity, pulmonary symptoms, negative intrathoracic pressure, and asthmatic therapy. Yeah, these are the things, asthmatic therapy and all. And asthma and GERD may exacerbate each other. Okay, and GERD may induce bronchospasm. As I said, the mild common nerve supply, breaking the cycle by aggressively treating both key mitigating patient symptoms. Next slide, please. So as a treating clinician, treating pediatrician, we need to understand the GERD and asthma association. Both together contribute to each other. When you are not getting a response, think of other conditions. Widely, there are many conditions which I told you, but we are talking about GERD. And symptomatology, barium meal and esophagogastroduodenoscopy, 24 hours pH monitoring. All these are diagnostic monitoring. All that we can do it, but more than that, these are like invasive investigation. Everything patient has to cooperate with the barium salvo. Younger the child, more the difficult or this test. But the most important is just the clinical diagnosis and giving a clinical therapeutic trial. If you give this a more simpler than submitting a child for invasive investigation, but still we if it is a severe and prolonged episode, better to document and treat. Next slide, please. GERD is suspected in children with asthma. The treatment plan is still debatable. However, the trials of PPIs is generally indicated, ensuring that this dose is sufficient enough to prevent esophageal acidification, and it's a course long enough to appreciate the subtle trends in changes in asthmatic symptoms. Next slide, please. Effective asthma management in this age group should address three broad domains. The first is pharmacotherapy. Yeah, what are medication? The next is treatment of comorbid conditions. Do not forget, and patients and caregiver education. Okay, these three. For coming to pharmacotherapy, before all this, first thing what we have to advise is a change in lifestyle. eating habit, sleeping habit, emotional stress, okay, and sleeping position, drinking less liquid in a GRD patients before going to bed, and losing weight, all the comorbid factors. Do not forget. First is pharmacotherapy. Yes, before that you have to change lifestyle. Pharmacotherapy, yes, whatever is required to relieve his bronchospasm. Treatment of comorbid factor, as I said, all that, and patients and caregiver education. Educate the patient. Without education, without explaining them, this is a chronic condition. This we are dealing with one primary asthma and associated comorbid factors. We have to treat both in between. In spite of all that, sometimes remissions and relapses can happen. All that is we have to explain to the patients how we have to manage when we get an acute episode of BC. And do not get panic. Do not, it's a like give them a how to handle at home if we get an acute episode. How to handle if he has just a seasonal or diurnal variations in a wheezing and coughing and all. So all this we have to explain to the parents and family members. Next slide, please. Mm. Okay, we have a standard guidelines. Okay, all of us we know the guidelines treating GINA guidelines. We have standard guidelines to treat. If we go through this chart, next slide. Yeah, if you go through this chart, no, previous slide, please. Yeah. It's in one slide is a lot of thing. If you see, there is step 1, step 2, and step 3. Okay, and if you see here, the GINA guidelines says that at what level and what symptomatology we have to treat the patient at different. And initially we have a bronchodilators, then we have a steroids, and then we have further pharmacotherapeutic drugs. Okay, and increasing the dosages and looking for other comorbid factors same time. Okay, and this is a standard which is recommended by the IAP guidelines. Next slide, please. Hello, next slide, please.
The slide visible to you? I have gone to the next slide.
Yeah, I'm
Primary
there.
care management of acute asthma. Yeah.
Okay. See, basically, whenever we have a mild, moderate, and severe episode, what we used to have, now the GINA guidelines has divided in more further details. Okay, yeah, and if it's a frequent wheezer or infrequent wheezer, if it is a mild, occasional, or more severe and frequent, or less frequent and more frequent and less severe, all that divided. And what is important is the meter dose inhaler is the primary treatment. Salbutamol, and we have a fluticasone derivatives. All that, these are the medications which we have to treat, depends on the severity. If he has an acute episode, just inhalers, the simple beta 2 agonist, that is a salbutamol inhalers therapy. We have to demonstrate the patient how to take it, how to deliver this, whether it's a mask or spacer, or always be encouraged with the spacer, not the directly into the mouth. Okay. So next is here. Suppose if you see here is in a mild moderate case, there is a phase prefers sitting to lying, not the agitated, respiratory rate increase according accessory muscles are used, pulse rate is more than 100. This is a mild to moderate. So how will it clinically different? For us is like a subcostal retraction. Okay, heartbeat is going up, saturations are ranging anywhere between 92 to 95. And suppose if beyond that, suppose if a saturation less than 90% heart rate, this is just to have a very weak evaluation at outpatient consultation. So we did not need to think whether it falls into or mild to moderate or severe case. If with these guidelines, we can differentiate the patient whether it's a mild, moderate, or severe by simple mathematical calculations. Okay, heartbeat is under 120 and saturation is 90-95 is a mild to moderate. More less than 90 and heart rate is more than 120 is just a severe case. And life threatening, definitely the CNS involvement. Okay, so very simple. If you ask me, more of respiratory complaint is a mild to moderate, and a respiratory complaint along with the serious involvement, that means heart rate is going high, it's a moderate, and the CNS is involved is a more severe life threatening. Transfer any severe end cases, we need to have emergency room facilities, and simultaneously we can provide him oxygen to maintain his oxygenation, and start the treatment immediately. So salbutamol inhalers, you can give it 4 to 10 puffs through spacer, and with a 20 minutes interval, at least try for three times, that is 20 minutes interval for 1 hour. Prednisolone, you can give it children's 1 to 2 mg per kilo, and control oxygen. And if he responds, then continue this, and then maintenance treatment. If he doesn't respond, then he'll go into severe cases, and if it is worsening, then he will go into systemic steroids and injectable medicine, good hydration, looking for blood gases and all that. Next slide, please. Next slide. Okay. And here is the same thing. The primary care, what is the primary care in patients in acute? And acute and subacute asthmatic, sorry, slides are changing.
Hello.
Sorry, yeah, I can see now. See, assess for the discharge. Once the patient is stabilized and everything, then you have to assess. How will you assess? His respiratory, like improving, and 60 to 80% of the personal, the best is predicted. Oxygen saturation is coming more than 94-95%. He's feeling comfortable. He can have a good breath count, breath holding counts, and he can feel more energetic and feels comfortable, and respiratory rate settling down. Retraction is much better. And then arrange it for discharge. Then how will you discharge? Yes, definitely. When patient feels comfortable that time, and we have to continue steroids for at least 5 to 7 days in a same 1 to 2 mg per kilo dose. And all these patients, you had to call them along with the parents for follow-up to educate them how to treat and how to handle at these episodes happening at home. Yes, simple inhaler treatment. You have to give 4 to 5 puffs with 20 minutes interval, give oral prednisolone, then call for medical help doctor. That means parents can do at home and then call for medical help for further treatment, can go to the emergency. Okay. Next slide, please. Next slide. Yeah, choosing an inhaler device for children years, 5 years and younger. Yes, very practical question, very important. We have to choose in a one is a skills training to use inhalers devices, encouraging adherence with the medications and appointments and other advices, asthma information and training in guidelines, self-management with self. And if you ask me, sorry, this slide is changing. Okay.
So
yeah, this
I did say asthma self-management education and skills.
Yeah, asthma self-management education and skills training. But the most importantly, education to the patient. If his patient is the elderly pediatric, and educating a parent. Now we have to spend. We have to give a positive explanation. Many patients, they have in fiction, this is the addiction medicine, because once if we start, it's very difficult to come out. That's what we have to say. What I explain to my patients is, like, if you have yeah, eye problem, nose problem, and ear problem, you use the drops, okay, just to control it. In the same way, 10 years down, before 10 years, we did not have a medical expertise to how to push a medicine into the lungs. Okay, and we used to take a oral medication, the same salbutamol, and that's a large dose. Okay, 1 teaspoon is 2 milligrams syrup. And if patient is 20-25 kilos, we give 10 ml, that's 4 milligrams, that's a 4,000 micrograms each time when he takes 2 spoons. It goes to the blood, and blood doesn't understand where we have to send this medicine. This medicine reaches to each and every part of your body, like a lung, liver, bone, muscles, brain, everywhere, and causes side effects in the side organs. And part of the medicine goes to the lung and gets a relief. The same thing what we are doing right now is giving a medicine straight away into the lung. We don't need to give 4,000 micrograms each time. We have to deliver one puff 100 micrograms. If it takes 2 to 3 puffs, 300 micrograms. Out of that, only 25% of the medicine goes to the lungs and gets a relief. That means if you take 3 puffs, out of that 300, only 75 micrograms reaches to the lung and gets a relief. Very minute dose and immediate relief, immediate. No, this medicine doesn't go to the side organs, so no side effects. And it's a great therapy. And we are lucky to have this kind of research and reaching to this kind of medicines we can deliver, especially even in children. When it has come into the market, only adults used to take. Now adults, pediatric, we had found out, oh, we can deliver to the space. And afterwards, then we realize, oh, we can deliver through even mask to a newborn to any age group. We are lucky to have this kind of research and developing and getting a easy medications and getting itself easy way of treating, simpler and less dose and all. So that's what I explain. As soon as I explain, parents get impressed. Okay, that's what we do in a practice. And without explaining, without educating them, if you tell them this is inhalers, you have to take it and just go through the video and all that, no. You have, when you initiate therapy, in my practical experience, always you have to spend 15-20 minutes with the patient, how to maintain this inhalers, washing, wiping, keeping cleanliness, how to use it, and after usage, sips of water, and keep comfortable. Let demonstrate on yourself. Parents can demonstrate in front of the child on their own, and then keep the child to the while playing like that. They happily take it. I never come across a child who is failed to take this MDI. Next. Asthma control may be difficult to assess the setting of unrecognized and untreated comorbidity. Definitely, there are so many comorbid findings that is a clinician job to pick up and take a detailed history in the beginning itself. We should not have at the end of a treatment when we don't get it. That means he's a clinician's failure. We have to pick up all the comorbid factors. If you have spent a good enough time in taking history, you can pick up all these conditions in early when patient comes to you. Next slide, please. Yeah, definitely. We had to treat GERD and always pharmacotherapy. What is GERD and how does we can prevent by changing lifestyle? Okay, drinking less liquid before you go to bed, eating small quantity, more frequently, lying down with the proper position, avoiding fried food and oily food and heavy food, all that. And walking after food, don't sit immediately and losing a tummy fat. Next slide, please. Is a combination of conservative measures. That's a lifestyle, as I said, dietary modification. And for a clinical standpoint, it is useful to distinguish between infant and young children and the children and adolescent GERD management, since the clinician clinical presentation of each or the age group is completely different, and we have to advise accordingly. Next slide, please. Conservative management of the current first-time approach in infant and GERD regrets from feeding, posture, and modification to modifying the maternal diet and maternal diet in a breastfed infants. Okay. In this line, management fails to improve symptoms and current pediatric guidelines advise 2 to 4 weeks trial with a cow's protein free diet by either excluding milk from maternal diet in a breastfed infants or by using a hydrolyzed formulas in a non-breastfed infants, hypoallergenic formulas. Okay, there is a consequence of fact that CMPA can resemble GRD should always be considered as possible differential diagnosis. Of note, this recommendation does not apply to the subset of GR patients with so-called happy spitters. Yes, happy spitters means patient continue to show regurgitation type, vomiting and everything, but they are happy. They do not lose weight. They eat well. They put on weight and they have no sleep disturbance. Comfortable. Next slide, please. So, in infant young children, especially the pharmacological treatment of GRD encompasses a secretory and prokinetic drugs. In infant, however, the use of this agent must be uh, reserved for patients with objectively assessed GRD and increased esophageal acid exposure. Older children and adolescent, yes, definitely when they describe to you in a very clinical and detailed manner, definitely they need a treatment, they need a lifestyle modification. Next slide. Yeah, it's a the flow chart which shows clearly upper gastrointestinal symptoms suggestive of GRD, and then the plaque symptoms investigate, and further feeding and strategies and personal his family and investigate pH impedance monitoring. All that, as I said, clinical trials and clinical therapeutic trials we can give. Yeah, if you see 2 to 4 weeks of CMP with free diet and improvement, and if no improvement, then further this line we have to go accordingly. And finally, the most important is the clinical response. Next slide, please. Next slide, please. Yeah, here you can see clearly the response. Okay, when you have, definitely at the end of it, it may take little time, but you can see the baseline response to effect of lansoprazole with versus placebo on the Juniper asthma control question. If you see, definitely placebo and this one. If you see the blue line and red line, okay, and there is a definitely almost parallel, and the end of it you may see a marginal difference in placebo and lansoprazole. Next slide, please. 4 to 8 weeks of acid suppression therapy is recommended to treat typical reflux symptoms. That means when you initiate, you may not see a response immediately. It may take at least 5-7 days. At the end of 4 to 6 weeks, you can conclude whether it's responsive or not. Do not forget changing a lifestyle. If you continue to take medicine without changing a lifestyle, you may not see a good response. That should only occur after dietary modification, yes. And avoid acid suppression in infants and children with esophageal symptoms, example, cough and wheezing and asthma. GRD complications should be assessed with the esophagogastroduodenoscopy and with the biopsies. We can see a morphological feature in scopies and come to conclusion. And the most important is the pH impedance studies are recommended to see the role of acid reflux in esophagus and whether acid suppression therapies and but as a clinician still we see go by the patient symptoms. If patient is feeling comfortable, whatever symptoms he had before the therapy, if he feels better, we give importance. If it doesn't respond, then we can go for further investigations. Diagnosing GRD with a salivary pepsin and extra esophageal biomarkers and scintigraphy is not recommended at all. Only use of manometry if there is suspicion of an underlying motility disorders, and positional therapy to treat reflux in infant is not recommended, and proton pump inhibitors can be used as treatment for erosive esophagitis. And do not forget, when infants and children, but infants who is the breastfed and who is wrapped tightly, diapers are tightly put, that increases the abdominal pressure and causes a reflex. Okay, that's also we have to, as a clinician, we have to keep in mind. Next slide, please. Next slide.
Summarize.
Okay, and to summarize, okay, I'm going to read these lines. Okay, and asthma and gastroesophageal reflux are relatively common diseases in children. The disease often coexist and some cases GERD will contribute to uncontrolled asthma symptoms. If asthma is poorly controlled despite adequate treatment, then GERD should be considered as a comorbid contributory factor. And impedance monitoring in emerging as a new gold standard for the diagnosis of GERD. And a therapeutic trial or anti-reflux medication should be considered in poorly controlled asthmatics, particularly in those who are atopic or have GERD symptoms. Never newer techniques such as measurements of pepsin in exhale breath, considerate condensate may help unravel the complex association between the asthma and GERD. These are the newer investigation, which is simpler in a breath pepsin levels. Yeah. Next. Okay. And that's the end of it. The message is, whenever you are treating the patient with an asthma, always take a detailed history and rule out comorbid factors. That's one. And the second thing is, depends on the age of the patient, and think of your differential diagnosis is a primary wheezing or secondary. And the third most important is uh, uh, educating a parents and explaining about the therapies about meter dose inhalers. Okay, these are best modality of treatment at present available for children and even in adults and infants and newborns right from newborn age. Okay, we are lucky to have this kind of supportive care and educating system to parents. Even the manufacturers of these all are, they are willing to support. They have beautiful videos to demonstrate to the childrens, and they are very helpful, and always they are, yeah, we don't take an help of them, but they are always willing to help, to educate and to help the parents or different parents and patients at any time of their therapy. Okay.
Yeah,
Thank you, sir.
Thank you.
So we have few of the questions for you.
Yes.
So I'll just take briefly. We have shortlisted 3 questions. So I'll ask the question to you, sir. So one of the doctors have asked a question: how do you rule out the diagnosis of GERD in an asthmatic child in a younger age group?
See, basically, as I said, right diagnosis and ruling out is right from the symptoms. As I said, excessive irritable child, asthmatic child, why should be irritable? Okay, in between asthmatic episode, he's not comfortable. Excessive irritable child, arching back repeatedly. Okay, and removing milk every time. And he's a very cranky child between 2 feet after full feeds also. That means the reflex, acid reflex is burning him. That happens in infants. In children, they eat less and they're little scared to eat more, and they vomit, and they have episodes associated with reflex associated with the wheezing. Okay, and elderly patients like who is above 8 years can describe your symptoms of chest, heartburn. Okay, these are the symptoms. Initially, we have to have the diagnosis. How will you differentiate symptomatology of the patient? Second thing is correlation between this reflux and wheezing. That's the second. Third thing is we can do investigations depends on the child's age. The best way is monitoring a pH levels in the esophagus. Okay, that tells you about the even minor most acid reflux, which may not be clinically we can't pick up, but definitely investigation picks up. Reflect documentation is we have many scans and plus scopies and pressure monitoring, all that. Next.
So, what is your drug of choice in management of GERD associated asthma?
Yeah, we have to treat first GERD, associated asthma. Both can contribute unless until we closely see which one is contributing more to other one, and we have to treat both. We have to treat both. Okay, we have to use a prokinetics and antacids. Proton pump inhibitors, but that happens only in elderly patients. But younger the patient.
Sir, you are on mute, sir.
Yeah, can you hear me now?
Yeah, yes, sir.
Yeah, proton pump inhibitors and plus prokinetics in elderly pediatric patients. Younger the patients, only prokinetics, and modifying more thicker feeds and all that we can do. And asthma, yes, definitely we have to have a both MDI inhalers for beta agonist. Okay, and plus we have to use a fluticasone inhalers to control chronic asthmatics.
So there is one more doctor says that can we use in younger children omeprazole for management of GERD associated asthma?
Yeah, younger children, yes, we don't encourage any this acid diluting medicine because we need just prokinetics. Absolutely, they get all right. We don't encourage omeprazole.
So in management of asthma and GERD, so what is your preferred treatment for treatment of asthma? It is only the ICS therapy alone, or it is with the ICS or LABA combination?
Yeah, see, basically, whenever there's an episode, we have to use a LABA because that's an wheezing time. But ICS alone is in between. Whenever he gets a clinical wheezing episode, we have to use both.
Thank you, sir. These were the questions we have received from the team. And over to you, Abhishek.
Yeah.
Thank you very much, sir. On behalf of Lupin and entire Fox, extend a very hearty vote of thanks to you, sir, for taking your important time and sharing the platform with us, sir. Thank you for accepting this invitation.
Thank you very much, Abhishek. I got an opportunity to express my practical experience and handling all these patients. We see a lot in our many pediatrics must be seeing day and night the same respiratory cases more than any other cases. I think definitely it's helpful for any one of us. When we attend, we learn many things. Even I see in my practice, when I listen to someone, I learn some new points every time. Thank you.
Thank you, sir. Thank you so much for your time.
Thank you.
Sir.
बोलो बंद करो कैसा करो चलिए